Hello, this is Ken Stoltzfus. Today I want to talk about the last three stages in the clinical psychology treatment process that we've been talking about here in Psychology 412, the clinical psychology course for LCC International University. And so we're going to start off by talking about intervention. Intervention is the third step in the clinical psychology treatment process. And simply put, intervention is the implementation of the treatment plan. So you've assessed the client, you determine whether they have diagnosis, you've developed a treatment plan that draws hopefully on research and theory around that diagnosis, and now it's time to implement that plan. And so usually a big part of that plan is going to be working with the client on resolving various symptoms that they are dealing with, and a lot of times we're trying to do that by using psychotherapy or the talking cure, as Freud called it. And so the idea here is that somehow our relationship with the client can be a healing tool or healing process for the person. And so we need to think about ourselves, the clinical psychologist, as our tool in our work. And so I often tell people, if you're a carpenter, you've got a hammer and a saw. If you're a dentist, you've got a drill. But clinical psychologists, you really are the tool that's used in your work. You don't have any other implement. Sometimes we do drawing or play therapy, but for the most part, it's us. And so we use ourselves in our work. And so this points to the power of the relationship that we have with the client. And I mentioned earlier when we were talking about treatment planning and evidence-based practice, I mentioned this common factors research. And this research says that there's something that most good therapists have, and it's an ability to be warm, to be empathetic, to connect with the client, to join with the client. And that seems to really do a lot of good for the client. Whatever else we do with them, if we've developed that therapeutic relationship, that seems to really often have a healing effect on the client. And so that therapeutic relationship is one that's characterized by empathy, putting ourselves in the client's situation, a warm regard for the client, what Carl Rogers called unconditional positive regard for the client. Also a collaborative or a partnering posture. We want to join with the client, be on the same level as them. It doesn't tend to work too well when we're the expert and then we sort of talk down to the client or we use a lot of jargon. We really want to be on their level. We also need to attend to boundaries and professional roles. And so it's not uncommon, because we're sitting and talking with a client for an hour at a time, once or more a week. That doesn't happen often in our culture. We live in a culture where sitting and talking with somebody for an hour straight doesn't happen very often. And so sometimes we start to feel very close to the client. There are even situations where clients fall in love with their therapists, or therapists fall in love with their clients. And I say fall in love, and I use that loosely, because usually what this is an infatuation as people have gotten to know each other, because they're spending so much time talking about intimate things. This can happen, and it's really important that the therapist is aware of that. And if the client has sort of fallen in love and begins acting romantically or even seductively towards the therapist, we attend to that in the therapy. We say, it seems like you've expressed an attraction to me. What does that mean? Where do you think that's coming from? Often that's a symptom that the person is lonely, that their needs aren't being fulfilled in other ways. And we want to try to help them learn how to fulfill those needs with somebody who's going to be a part of their life for longer than we will be, because we're going to have that short-term professional relationship with the person. If the therapist or the psychologist starts feeling romantic feelings or feeling of falling in love with the client, that's also important. And it's important to talk to your supervisor about that. Clinical psychologists, it's very important for us to have supervisors. Even if we have our own office, it's really important to have a colleague who meets with us and goes over our cases to help us remain objective and professional. And we also need to know that sometimes developing those feelings is a normal process. We should never act on them. We should never tell the client we're in love with them. We should certainly never become romantically involved in clients. In fact, here in the U.S., if you do something like that, if you become romantically involved with a client, you can lose your psychology license, you can be disciplined, you can lose your job, you may not be able to ever practice again. So there are harsh professional sanctions for doing something like that. But having those feelings is actually a fairly normal thing, and most psychologists, if they're honest, will tell you that if they've worked long enough, they probably had a feeling of attraction to a client sometime. And so we need to realize that we don't completely control those emotions, those feelings, but we do control our behavior, and we need to not act on those. And we shouldn't disclose them to the client. That's not something that needs to be brought up into the session. In general, we want to be careful about self-disclosure, and different therapists have different styles. And here I'm talking not about self-disclosure about romantic feelings, but more just about disclosing whether we've had personal experiences and feelings that mirror or are similar to those of the clients. People have different personal styles here. Some therapists do a lot of self-disclosure, others don't do very much at all. People who were trained more than 20 or 30 years ago, back when most of the clinical psychology training was psychodynamic and Freudian, they were taught not to disclose at all to their clients. People who were trained since then, the time that I was trained, we were taught that it's okay to have a different sort of relationship with our clients, to disclose a little bit. And the truth is that there's some research out there that say that clients find it helpful when therapists disclose a little bit, when there's a little bit of self-disclosure. But in general, it seems like general self-disclosure rather than specific self-disclosure is maybe more beneficial to the client. So here's an example of what I mean. In the U.S., there are a lot of people who served in the Vietnam War back in the 1970s. This was a very unpopular war. It's a war that eventually America lost. We ended up just pulling our army out, our soldiers out, because it wasn't going well for us. And there are a lot of people who came back from that war really in bad shape. A lot of them have had drug and alcohol and mental health problems since then. So they're a population that certain therapists have worked with a great deal. And one time I was at a training session that somebody who worked at one of our veterans hospitals was talking about, or was giving. And during this workshop, the person said, I have a lot of my clients ask me, were you there? Were you in Vietnam? And he said, I'll just tell them, yeah, I was there. And he said, I don't go into what I saw and what I did and how it affected me and the feelings I have and whether it affected my mental health or not. I don't tell a lot of war stories about where I was and the fighting I did and how many people I shot. He said, I'll just give a very general self-disclosure and say, yeah, I was there. And he said, usually that helps my client to feel like I might understand a little bit more of what they're talking about because I was there. The big thing with self-disclosure and boundaries is we want to make sure that whatever we do is meeting the client's needs, not our own needs. So if I had a really bad time with my boss and the client's describing having a hard time with their boss, this isn't the time for me to start complaining about my boss because that's meeting my own needs. That's letting me vent and kind of have some catharsis of my own. That's not meeting the client's needs at all. It's dealing with my issues, not the client's issues, and that's what we want to avoid. So once we've done the assessment of the treatment plan and we've done the interventions for a while, then at periodic intervals we need to stop and assess, or let me use the term evaluate, is the intervention working? Is the treatment plan working? And so sometimes we do this in a formal way, so we might have repeated measures that we use with a client. So we might give a measure when they first come into treatment, and say a measure of depression, and then we might give that same measure 3 months later and see if their symptoms have improved. So an example of that sort of measure would be the Beck Depression Inventory. That's a 20-item measure that measures whether somebody has depressive symptoms or not. And we might see, did their Beck Depression Inventory score improve after 3 months of therapy? And if so, then we have a sense that what we're doing is working. You also sometimes hear about RAIs, or rapid assessment instruments. These would, again, just be short instruments that a client could take to measure mental health symptoms. In the U.S., the funding that our agencies receive is often linked to some sort of formal evaluation. And so we have to be able to show agencies that give grants or that pay the bills, that provide the money that is paid to us for working with clients. We have to be able to show them that what we're doing is working. And sometimes we have to do that in a formal way. Like I said, with repeated measures through more of a research kind of process. A lot of times what we do, though, in clinical psychology is we just discuss with the client. We say, are you feeling better than you were when you came to therapy? What's working? What isn't? Are there other things we need to add to the treatment plan? And so usually this evaluation goes along with updating the treatment plan. The client might say, yeah, I'm not feeling so hopeless and sad anymore, but now what I'm trying to do is really rebuild some of the things that fell apart when I was hopeless and sad. So I'm trying to rebuild my relationship with my wife. I'm trying to get another job. And so we might change the treatment plan to update some of these more practical things that the client's working on. And so what we want to do is we want to evaluate, change the treatment plan, then we work the treatment plan, we do more interventions for a while, and then we evaluate again. And so it's kind of this constant cyclical process. Finally, after we have worked with the client for a while, and the client has hopefully improved, we get to the point where we start to think about termination or ending our work with the client. And this is what we should be working toward from the very beginning. We need to be working towards termination from the very first session. And it's important to remind our client, definitely in the beginning and sometimes throughout the treatment, that we have a time-limited professional relationship with that person. And so they should know, I'm only going to be working with this clinical psychologist for a few months or maybe at most a year or roughly a year, because this isn't something that's just going to go on forever. Hopefully, if all has gone well, we terminate with the client through what's called a successful completion or successful discharge. And this is where the client's gotten better, we know they've gotten better, and so we begin to talk about the termination process 3 or 4 sessions prior to discharge. So it might be that we've assessed the client, we've developed a treatment plan, we've intervened, we've evaluated, we've gone back and we've updated the treatment plan, we've done more interventions, we've evaluated again. And finally, the client says, I'm really feeling a lot better. I don't have a whole lot more I feel like I need to talk to you about or do with you. And you say, yeah, I agree. I really think you've made great progress. Usually what we want to do is we want to start having those conversations then 3 or 4 sessions before discharge, or at least 2 or 3. Often we want to explore that idea for a session or 2. What would it be like to end the treatment? Are there any other things that you think we haven't really worked on yet? After we've talked enough about that, then we want to say, okay, well, maybe let's take an extra couple weeks. If we're meeting once a week, let's wait 2 or 3 weeks to meet again, just see how you're doing, because we don't want to cut things off really directly. And if things are going well in 3 weeks, then we'll have maybe one more meeting after that, and that's when we'll do your formal termination. So we want to give the client time. We want to maybe space things out a little bit more to see how they're doing. And then that last session that we meet, we want to develop aftercare plans. So it might be that the client doesn't need therapy anymore, but maybe there's a support group they could go to, or maybe there's something at their church that might be a good thing for them to get involved in, or maybe there's a group of friends that have really been supportive that they need to see more often. We want to develop plans for how to keep the progress that they've made continuing even after treatment. The other thing we want to do is we want to discuss the process and the criteria for re-entry into treatment. So some of the diagnoses that our clients might have, things like depression, they tend to be cyclical, and it's not uncommon for people to have depression, to get better, and then to relapse into depression in 6 months or a year. We want them to know how they can come back to us if they need to. And so we might say, if you start feeling depressed again, if you start feeling sad or really upset. Sorry, my computer is doing something weird here. This is how you get back into treatment. That you can call me at this number, and we'll set up an appointment, and you can come back in. So it's pretty basic. We just want to make sure that they have our number and that they kind of know how to come back if they need to. That's a successful discharge or a successful completion. A couple other ways this can go. One is what's called an AMA, or against medical advice discharge. And this is just like what it sounds like. The client decides that they don't need treatment anymore. We don't agree that they're done, but the client just says, I'm not coming back. I don't want to do this anymore. That happens maybe more frequently than we'd like. Sometimes it's also considered, or sometimes it's also called an against staff advice. You might see that instead of against medical advice. But this is where the client just self-discharges. They leave, even though we think that they still need treatment. The other thing that might happen is the client could need treatment, but we decide that this isn't the right place for them to be, that they get an unsuccessful discharge. And this might be that their needs have changed, or our assessment of their needs have changed. For example, I have not worked ever with somebody who has an eating disorder, and if somebody came to me because they had a substance abuse disorder, and they got their substance abuse treatment under control, or their substance abuse under control, but then it came out that they had this eating disorder, I might discharge them and refer them to somebody else, because I'm not really an expert. I'm not really qualified to work with people with eating disorders. So that would be a sort of an unsuccessful discharge from us, but a referral to someplace else. The other thing that might happen is we might need to do a therapeutic discharge because the person is having a negative effect on the treatment or the safety of others in the program. And so sometimes when I used to work with delinquent boys with substance abuse issues, sometimes those boys would become violent and they wouldn't be appropriate for the programs we worked in because we didn't have a way to keep the other boys safe. And so even though my client might still need treatment, I might need to send them someplace else to get that treatment. And so then we had to unsuccessfully or therapeutically discharge them from our program. Okay, so this is a little bit about the last 3 stages of the clinical psychology treatment process. Hopefully that gives you a good picture of the whole process based on the previous lectures we've had as well as tonight's. As always, I hope you're having a good week, and I will talk to you again soon. Bye now.